There we go.
Perfect, great.
Okay, so hello to all of you there. It's pretty and nice and warm in Driggs today, so that's nice. And I'm sure it's probably the same there. So the first slide that kind of gives you the overview of what I presented at the national conference. At our little hospital in Driggs, we just really didn't have very much of an antibiotic stewardship program. And so we tried to find something that we could do that wouldn't cost too much because we don't have a very big budget because we're such a small place. And so I hope that as we kind of talk through this, and you're welcome to comment if you have more. I hope that it won't just be for a small hospital, but maybe some of you, are having trouble, at even bigger facilities or long-term care or whatever. So hopefully it'll give you some ideas. So if we go to the next slide that says objectives, this is just to kind of give you an idea of what we're going to talk about during this presentation. And so for my own self, thinking of my small hospital, we just had these things that we wanted to answer. The first one kind of being, where do we start? And so we really didn't have anything in place, like I told you. We were, I would say, I don't know what the word is, just not documenting that we were keeping track of anything. We were doing what probably everyone does, seeing which antibiotics the doctors are prescribing the most. We were tracking, informally tracking things. We were checking every day to see how long people had been on antibiotics that were in the hospital, that type of thing, but not anything formal, no reporting within or without. So then the next question was, what are the obstacles we face? So one of the biggest obstacles was I couldn't find a way to pull the data from our EMR. It was very difficult. And we used, we had just switched our EMR to one called Athena, and some of you have heard of that or not. But anyway, I couldn't find a very easy way to build a report, to pull the data out. So that was probably our biggest obstacle, I would say. Then the resources that we had for the third question, we have a really good C-suite that is very supportive of antibiotic stewardship. Anything that I want to do, they're very supportive of with infection prevention. So I felt like that was a great resource. And then, of course, I'm a member of APIC, so I count that as one of my biggest assets that I have, because you automatically have that networking across the state of helpers. And so we had that going for us. And the same thing, who can help us and where can we find help with funding? I feel like those all tie together. And so one key, I think most of you know Stephanie Seha, and she had got a speaker, and the man's name I'll slaughter. I'll just call him Dr. S. But this was at a conference that that Stephanie helped put on, and she had found the speaker, and he was this Dr. S from Utah. And he's the one that kind of was instrumental in a key piece that I needed that I'm going to tell you about in just a little bit. So then if you go to the next slide, there's 3 pictures there. So on our team, as far as resources, I had Brad, who is the pharmacist, and he was very willing to help. He wanted to do a formal antibiotic stewardship program, but he was having the same trouble, trying to pull data out of our EMR without having to hand do everything. And then in the middle, we had Angela Booker is my CNO, and she's also very supportive. She's over my department, infection prevention and control, as well as pharmacy. So, she was automatically on our board. And also our CEO was supportive. And then there I am to the right. And so I head up our antibiotic stewardship program with Brad. We were kind of the team leaders of it. And then we have our meeting, quarterly. And so we have other people that are listed there, all those different managers, like the surgical manager, the lab manager, maintenance, all those people that come to our meeting that were also on our antibiotic stewardship team.
Here we go. There they are.
Do you see them?
Yeah, Nikki, sorry, we were a couple slides behind, so we just caught up.
Okay.
And we see you now.
So now you're good. Okay. So if you go to the next slide, it looks like just a medication administration record. So I wanted to kind of show you this. These two slides won't mean a lot to you, but just to kind of show you the reports that we finally figured out how to pull. And so our pharmacist, was able to figure out how to pull this from our medication record. But the part that's in between, when I said that that Dr. S gave a talk at that 2017 conference, where I think a lot of you were probably there. And he said that there was a company out there, and he told us the name of it, and it was called ASOLVA, ASOLVA, or another name they call themselves is Medici. And he said, just briefly mentioned it, and I happened to have my pen and jotted it down, thank goodness. But so this company, Asolva, is a web-based company, and it's kind of an interface between people's electronic medical record system and NHSN. And so this company helps you get your information out of the MAR, your medication administration record, and your EMR, and pull the data into a form that will cross over and can go into NHSN. And so I felt like that was our key. And then the best thing about it was this company only charged $50 a month for the service. And so we thought that was kind of unheard of. We'd never heard of anything like that before. And what's kind of comical to me, after I spoke at the national conference, I got an email about 2 weeks later from this ASOLVA company, and they've doubled their price. And so they said they've been selling a lot more of their product, and now they feel like they're very valuable, and so now they're going to double the price. So it's still, only $100 a month for my hospital, but they're going to start charging $100 a month. So I thought 100% increase in price was interesting. Anyway, so that's kind of the back part of this. So Brad, our pharmacist, was finally able to get these two different files that you can kind of see. And there's, a few of them that he pulls now. But this was the part that was so very difficult that took us probably 4 or 5 months to get to this point, because the guy from Asolva would meet with us like in a webinar like we're doing, and he would have some slides and coach us through what Brad needed to try to pull from our, medication administration. And so he was finally able, I'd say it took him 4 to 6 months to do it, but then he finally got these reports, and then our Asolva rep would teach us how he would, our pharmacist would upload them to the website, and the floating kind of cloud thing, and then I would log in and I would move them from the Asolva website across into NHSN. So we were finally up and reporting, and I think it's probably only been a year or less that we've been doing that. But Brad had the records back. He'd kept the data for the last few years, so we were able to move. It's all of 2019, but all of 2018, and I think part of 2017, we were able to move because once he knew how to create those reports the way they needed to be to go to NHSN, then we could put all that into NHSN. So we have all that data in there now. And then if you go forward again to the next slide, I think it says location transfers, and that's just another example of, what he was pulling. And then if you go to the next slide, does it say surgical antibiotic improvement program?
It's the pharmacist uploads into his reports into the cloud.
Okay, good. All right, so those are just to show you examples, and it might not stick in your head at all, but just to give you examples of what that looks like, all that interface. So the first ones that just said medication administration record and like admissions and discharges and location transfers, that just came out of our EMR. So in case anybody was interested, I just wanted you to see kind of what that looks like. And then the slides after that, the next few slides are showing that company what a Salva looks like, or Medici it's called. So it just kind of shows some of the steps that I would do, just to kind of show you what it looks like inside of that Salva. And then I think you can forward through those next few slides until you see one that says Surgical Antibiotic Improvement Program, and I think it says low-lying fruit.
Yes, we have that up now.
Okay. So on that part, to me, that's what was the most exciting part. And so you can see at the top of that where it says Q1 2018, and then he compared it to Q1 of 2019. So we had started that program right before Q1, where we actually had all our equipment, so to speak, and our programs up and running. And so then when he compared those 2 years, so we've been doing it that whole year, there's a big reduction. So I have to do a side note. Another thing Brad did, the pharmacist, he went to our orthopedic surgeon, who was our low-lying fruit, because he does the most of the surgeries that we do, all of the total hips and total knees, and all of the bone things, all of the orthopedic things. So he does the most surgeries at our facility by far, and he uses the most antibiotics by far. And so what he was kind of doing is he would have a pre-op antibiotic, say like on a total hip, he'd prescribe Ancef 2 grams or Ancef 1 gram, and you'd give that right before the patient went back to surgery. Then they would wash some of the wounds or bones with an antibiotic wash, in the solution. And then they would have antibiotics after surgery in the post-op, and then they would have it for 3 to 5 days while they stayed on the floor in our hospital, like every 8 hours, IV around the clock. And so he's a well-known, educated doctor, but we wanted to try to go to him first and see if he would change, try to change and reduce the antibiotic usage, but we knew he would only do it if it was presented in the right way. So we found a lot of literature and scientific research, with the latest recommendations for reduction in antibiotic use, that it was validated, that it's not good to do it that much. And so Brad did a presentation with that orthopedic surgeon and his assistant, and I think Angela was there too, Angela Booker, that I had showed you her picture, our CNO, kind of the little committee. We did it. And Brad just presented all that data to him, all the current recommendations. And at the end of that, I thought Dr. Brown would say, no, we're not going to do that. I don't want to do it. I want to do it the way I have been. But to our surprise, he said, I'm willing to try that. He said, I didn't realize that was the current recommendation. And he said, I'll try it for 6 months. And he said, as long as our surgical site infections don't go up, I'll keep doing it. So we were very pleasantly surprised. And we went out of the meeting and wanted to jump for joy because we were so surprised. But he did that. And so starting the very next week, they stopped prescribing that. And so they started doing, say, Ancef right before they go back to surgery. And then that might be all. Unless they had, high risk factors, that might be all that they would have, even if they stayed in the hospital for 3 days recovering. So that was exciting. So if you look back on the low-lying fruit, that thing in front of you there on the screen, the post-op antibiotic doses in that 1 year period went down 57%. And I didn't worry about the cost. Our pharmacist was very excited about the cost. I don't really care about that so much. But the irrigation doses that I told you about, they were reduced by 52% in that first year. And our floor doses were way down, 82% from what they had been. And then just total doses, everything mixed together was down 64%. So you can imagine our hospital administrators were excited, and all of us nurses were excited about the reduction. And so now, now that we've done this for a little bit, we just try every month to submit the reports that I can get off NHSN, like say a bar chart or one of those pie charts, and we just send them out to all the providers and to all of our medical staff. And we'll put that in our newsletters. We have a newspaper that's called The Scope, within the hospital, and just put that word out every month so that they know what our antibiotic usage is and, any reduction or increase that we've had. And I've been surprised that it's been a really good response. And Dr. Brown, of course, was thrilled because of that, our numbers went down that much and we didn't have any increase in infections. And we just kept it up. So now that we set the system up, it's easy to do it every month. And we had a goal. We wanted to be reporting to NHSN, and now it's easy to do it. So that's really all. Does anybody have any questions about that?
I have a question. This is Marwan from Saddle Ponds. Do you have an enhanced recovery program for your ortho joint replacement services?
Can you say that first part again? Do we have a what program?
Do you have an enhanced recovery program for your ortho surgeries, joint replacement? These are programs to improve the outcome of the patients. Some measures is taken preoperatively, and others like during the procedure, and others like after. And these kind of address the antibiotic stewardship as well.
Yes. I would say yes. I don't know if it's exactly what you're referring to. We call it at our hospital a SPA clinic, like SPA clinic. And so there is a pre-op meeting with various different people, that will be dealing with the surgery, the billing, the nurses, the providers. And there is afterwards as well, kind of a follow-up. And they do talk about antibiotics. So you're right. They discussed that before, and they did implement that about the same time that we started the more formal antibiotic stewardship. So yes, they do talk about the antibiotics before the patient even comes to the hospital and after too.
Thank you.
Yes.
Any other questions for Nikki? Thank you for sharing that with us, Nikki. That was really wonderful. And congratulations for getting to speak at National APIC. That's pretty cool.
Yeah. Well, thank you. Thank you guys for listening.
Of course.
Good outcome.
Next we have Holly. Martha, do you want to introduce?
Yes. So I'll just point out we have 50 years of experience between these two speakers. We have 28 years of nursing from Holly Williamson from Avamere Long-Term Care Facility, and she's done a lot of different things and a lot of things in quality, and her most recent job is staff development and infection control at Avamere, and she's also a CPHQ, Certified Professional in Healthcare Quality, for 18 years. So that's awesome. And are you working toward your master's degree?
Yeah.
Okay, in nursing informatics.
Nursing informatics.
And so she is trying to use this in her infection prevention role as well. So welcome, Holly.
You guys can share those.
Did you want me to advance the slides for you?
Yeah, I'll let you know when, or
Okay.
you can give me the mouse, either one. Pass that way. Put that one that way. And you guys get the last two. All right. So Avamere is a 88-bed long-term care and short-stay rehab. We have 22 beds dedicated to short-stay rehab, and then the rest of the remaining beds are long-term care. So we are downstream from most of the acute care hospitals as well as the LTACs. So we get the people who either need a little bit more push to get home, or they are no longer candidates to be at home because they simply can no longer take care of themselves. So that gives us a few different challenges than you guys have in the acute care setting. So go ahead and move to the next thing. So I'm going to talk about the drivers behind our program, give you a look at some of the forms that we have and use in our program, talk about some of the data and trending and where we put our data so that we can see how we actually bump up against other people. And then I'll be happy to take any questions. And I'm one of those, if you've got questions, raise your hand, and I'll be happy to stop what I'm doing. So move on to the next slide and bounce again. So the drivers for us predominantly are CMS. Our CMS regulations speak specifically to the fact that the facility has to have a program. We have to try to stop infections from happening. We have to address hand washing. We have to have a way to put residents into isolation. We have to prohibit our staff from coming in and have infectious diseases from taking care of our residents. And that's about as broad as the regulations get. So there's a lot of room for interpretation. There's a lot of gray area. There's a lot of how do you really do this. So our last survey, I can proudly say that, as everybody in this room knows, hand washing is low-hanging fruit. It's easy for every surveyor to hammer you on, and it's almost unexpected. You almost have your plan of correction written before they walk out the door. Mike and I can proudly say that on our last survey, we did not get a hand washing tag. That was probably one of our greatest achievements during that survey. So we've worked hard with the staff to deal with, again, what is the low-hanging fruit. So as we've moved through this process with these very highly specific regulations that we deal with, I've kind of sort of decided where we're going with the program. I have the support of my leadership from the administrative perspective, and that's key to anything. We have a policy and procedure manual that's almost as specific as those regulations. So I have that to, of course, lean on as well. We don't have any Joint Commission ties. Nothing that we touch is driven by any of the Joint Commission regulations, so we don't have that as a resource. And I have, kind of through dumb luck, stumbled my way onto the Agency for Healthcare Research and Quality, who is doing an antibiotic stewardship mentorship program. So they are helping me build this. So they're probably my greatest resource. They have webinars and all kinds of stuff that are available. They have forms, and you'll see a bunch of them in this process. So go ahead and go on to the next slide. So we voluntarily joined this, what has become sort of a labor-intensive process, goals with creating a safety program for improving antibiotic use, but the biggest thing that it gives us back is it gives us benchmarking. So we have a way to look at what we're doing up against same and similar facilities across the country. So go ahead to kind of bounce through that. So you actually have this in your packet. This is the form that I fill out on every single person that comes into my facility that has an infection. What it helps me do is it helps me make sure that our staff are meeting criteria for urinary tract infections, upper respiratory infections, a myriad of different potentials. It also helps me sort of classify things and track things and put them in the right same and similar boxes. What it doesn't handle are patients who come to us on long-term antibiotic therapy. They don't really have a box on here that I can check and address. So all forms, positives and negatives, they all have pluses and minuses to them. So it also sort of talks to individual risk characteristics, things that go on, gives me a place to track when cultures were done, what the results were. It just gives me a place to kind of collect all of the different information, what antibiotics they were put on, what precautions we put in place in order to deal with it, and then on the back, it gives me the opportunity to track my reporting, both to the state. My assessment of it, predominantly, we used to put the stuff only through our QAPI program, but we've now added and have the ability to increase our surveillance data as well as our antibiotic stewardship data. So this is sort of my go-to for everything that I do. Oh, no, I bought it.
Oh, okay.
If I made it, it would have addressed those other things that are.
She's kind of this.
No, we get all of our, this is through MedPass.
Okay.
So, again, it's just sort of a standardized form, but I make it work for what I do. Also attached are the different SBAR forms. It's the next slide. What's in the picture is our UTI form, which the biggest problem that we have is with our SBAR forms that we've since figured out is nobody knew we had them. And we don't have the ability because of our corporate environment to build them into our EHR. That would be ideal because then the nurses would have them whenever they wanted. Doesn't require them to run up to the nurse's station to grab said form. It's just not something they think about. My quality background, I have background in Toyota Lean and all of that, and it's all about having the forms where you need them. So being able to put the forms in the EHR would be ideal, but not an option as of today. I continue to push and poke and prod to get them there. And we have pretty high staff turnover, so somehow the communication during orientation that these forms even exist has gotten lost. We figured that out. We've started re-education on the SBAR forms. We actually have 3 SBARs specific to infections. They are in your packet. There's one for urinary tract infections, there's one for upper respiratory infections, and there's one for skin and soft tissue. Those being the 3 predominant infections that we deal with in our location. The beauty of the form is it's something that I stole from, in its original form, I stole it from AHRQ. It was about 6 pages. Each one of them was about 6 pages long when I first got a hold of it. So I took what I felt was the most important information and redeveloped the form. The beauty of the form is that on the front it tells you this is stuff that we want to watch, track, and trend, or is it something that we need to call the doctor and immediately get orders and start moving on. So it helps the nurses problem solve those infections sort of on the fly. Also, the back part of the form, it can either be faxed off to the doctor or put in the doctor's folder for them to review, or you can go over it with them on the phone. So it also gives the nurses cues as to what they should be asking for from the doctor, or it cues the doctor if they're looking at the form as to what things we want to watch on the backside. So, and they're specific to the type of infection that we're dealing with. So it, again, anything that helps nurses do that critical thinking is always an important aspect. Go ahead and bounce.
Okay.
And now one more. One of the things we also do, which is a benefit of this AHRQ, those initials will never come out of my mouth, is what we call a form moments form. Because we do get residents that come to us on antibiotic therapy that we don't have any control over the prescriber and what they did and why they did it, but based on the information that they give to us, which is next to nothing, we can then look at where the resident is currently in their physical health and decide whether or not this is something that we're going to continue on our end and how long we're going to continue it for. So I work with our medical staff. I have 2 MDs, a nurse practitioner, and a PA. that I have access to. They're actually all St. Luke's doctors that work very closely with me and with our staff to address, is this something that we still want to take forward? Is this to the benefit of the resident? Are we causing more harm? Is this something that we want to continue? So we fill those out at the 3-day mark post-admission to see if they're not already done with their antibiotics. Oftentimes they'll come in with 24 days, 24 hours left to go, 36 hours left to go. So it's a couple of doses and we're out. By the time I even figure out they've been admitted, they're done. So, but for those who are on longer-term antibiotics, we do this. Next slide. So when it comes down to the analysis of this data, next slide. We started out, we just trended it over time. We look at various, areas, we trend our data. We'd be like, yeah, we're really bad this month. Okay, we're better this month. Kind of sort of the standard data analysis that most everybody does. But there's no drill down, there's no getting into it, there's no figuring out what can we do better. So we took it to the next step with the AHRQ, and go to the next slide. And to them, we report what antibiotics we started and how many days of therapy our residents were on for each one of those different antibiotics. We report specifically on C. diff to AHRQ. That's the only one that they care about. Bumps up against our patient days so that we can calculate our numbers over. Sometimes it's 100 or 1,000 patient days, sometimes it's 10,000 patient days, just depending on what we're coming up against. So we have a broader way of looking at the actual antibiotics that we have going on. Go to the next slide. So this is the first month's worth of data that we've hit, and we are not real happy about these numbers. So based on this now, instead of just having it as floppy and sort of just looking at a month over month, what's going well, what's not going well, we've now got a way to look at our data up against 196 similar facilities that we didn't have before. So our data, predominantly outlier. This is just one example, but I think if you were to look at the entire report, we pretty much outline on every single element that we hit. So that has become the impetus to us to put together an antibiotic stewardship meeting, and now we have something concrete to discuss. Before, we didn't really have anything concrete to discuss. We didn't have a, hey, look at, we really are not good at this. And so we now have the ability to see all of the opportunities and how we can go about changing it. A few of the challenges that we will come up against is many of our antibiotics are prescribed for long-term wound patients and patients that come to us for long-term antibiotics because of a septic joint. So we have a lot of washout, we have a lot of bad joints, we have a lot of wounds that drive our antibiotic usage. Most of that is done by infectious disease doctors here in town. Many of our patients are up against having 2 or 3 antibiotics being prescribed for them, which inflates our numbers by up to 3-fold, because they're on them for 30 days, they're on all of them for 30 days. So those are things that drive our data. The one place where we are actually successful, besides the hand washing, is that we do not have a sustained problem with our long-term Foley catheters. We have both suprapubic as well as long-term indwelling catheters for some of our residents. And we do not have, at this point in time, any issue of sustained infectious disease in any of our Foley catheters. In our HSN data, we only report C. diff. That's the only thing we report. We don't report anything else to them but that. So our HSN reporting and the reporting we get back from them isn't as robust as what you guys get in the hospital. Ours is, yeah, you had them or you didn't. Oh, well, I already know that. Thanks for playing. So this to us is really, really helpful data and really is what's going to start driving us to improve our programs in the ways that we can because we don't have control over our outside providers.
I have a question for the benchmark through AHRQ. Are they looking at like facilities that they're benchmarking?
Yeah, so I had to provide a whole bunch of facility demographics so that they could put us all in the correct bucket. So yeah, it's based on bed size, it's based on population, whether we're an urban center, which we're considered, versus a rural center. So we come up against so we're supposedly in the right bucket.
Okay.
So yeah. And then that's kind of the end of my presentation, because now we're sort of in the infancy of building our antibiotic stewardship program. We've done just the tracking and trending for 18 months, almost 2 years. But now we actually have something that tells us something about what we're doing that's actionable. So that's where we're at.
Great work. Great. Yeah. Great work. Any questions for Holly?
You can keep it, it's entirely up to you.
I have a question. Is it okay to post these on our website?
Yeah. None of this is,
Is it one that you purchased, something we shouldn't post, or do you think it's all right?
it says it's copyrighted all over it, so if somebody chooses to steal it, that's on them. Most people take it and modify it and change it into their own kind of form when they do that, so. It's not an expensive form. If you choose to go there, I think a pad of like 100 of them costs less than $10. So it's not, if you choose to go with the form, it's not an expensive form to purchase.
You're paying for the tear-off pad.
Yeah. Pretty much.
Well, I really applaud you because, even the big hospitals, everybody's having trouble, like, tracking this and getting any kind of benchmarking. Really, the only way to do it is, like what Nikki described, through NHSN. But the AHRQ is a great program for that benchmarking piece.
Right. And it is it is our bucket. It is long-term care. It is specific to
Yeah, and that's the only place, because you can't, NHSN isn't even available.
Yeah, it isn't.
But just an FYI also, they did one for acute care a year before the long-term care, and next year, starting in January, they're doing one for outpatient settings. So if anyone's interested in that, I know I sent something out to anybody that was involved in our outpatient setting. So St. Albans, somebody got it from St. Albans, but if anybody's interested.
NHSN is having?
It's AHRQ.
AHRQ, okay.
So a similar thing to what Holly's doing, so you'd be able to benchmark with your cohort, and they give you all kinds of great tools and support. I've just heard fabulous things about this at AHRQ, although a lot of work too.
But I can say that initially the paperwork and getting all of the pieces in place was a challenge, but literally the data entry that I gave you is on that form. What I give them is that one form, and they take it from there. So it's not as labor-intensive anymore. In the beginning, getting them all the demographic information and creating the buckets and all of that was a much bigger challenge. Yeah.
What type of resistance did you face with your providers or leadership?
I don't think any. Our doc, we've gone through some transition in our medical staff, but Dr. Beeson is our medical director. She's been on board since day one. She comes out of the St. Luke's system, so this isn't new to her at all. We've changed sort of who our providers are, but she hasn't changed. So I haven't, and my leadership's all been on board since the beginning, and so I haven't had any resistance from my leadership staff. The rest of my staff is a whole different ball of wax. They're like, what do you want me to do? How do you want me to do it? So that's a bigger challenge, but it's a challenge that we've all had to face. you know. But no, I've not had any challenges from a leadership perspective.
You said you got the SBARs from HRQ?
Yes, they're based on an AHRQ SBAR that was out there. But like I said, their original one is like 6 pages long. And to me, it seemed fairly redundant.
Yeah.
So I just got rid of the redundancies and got rid of the stuff I didn't like and kept the stuff I did.
You have to have a bloodstream infection one?
Huh?
You have to have a bloodstream infection one?
I do not know the answer to that question. AHRQ does all settings. I use them a lot when I was in the acute care setting. They have a ton of resources and stuff, and they're kind of forgotten about. So I bet they do have something that you can use.
Cool. Any other questions for Holly? Awesome. Well, thank you so much. I really appreciate your time. Great job.
Thank you.
I think we have enough time to do our CIC questions. We weren't able to get to them last time, so we're going to pull up the June questions. We'll see if we got to the one that we're already. What we have in here. Do you want me to look in here? All right, let's see what we got here. Oh, we get it. Oh, here it is. Okay. Do you want to?
It doesn't matter, anybody can read them. You want to read them, Jim? You're right there in front.
Sure. Okay, so Kathy put together some CIC questions for us. First question is, we have a fruit fly infestation. A tech reports an infestation of fruit flies in the sterile instrument storage room. The sterile packs were temporarily removed, and a pest management company was called in to eradicate the flies. The OR staff wants to know whether they can use the sterile packs. Which of the following is the best response? I'll let you guys read those and let me know your thoughts.
I'm going with D.
I would say CC as well.
This is the one that's always the big.
Yes, they need to be completely reprocessed. And there's the reference, that's bottom chapter 106 of the APIC text, sterile processing. Number 2, initial outbreak investigation. The primary components of an initial outbreak investigation are preparing a line list and an epidemic curve, notifying key partners about the investigation, continuing case findings, or initiating an analytical study. Choose all that apply. Definitely one.
Want me to go to the next slide?
Sure.
The answer is, let's see.
All of them? So I'm going to go back. Or?
No, so go to the
Oh,
next one,
okay.
and then it's A,
Oh,
B,
then
C, or
it's
D.
like,
So
okay.
you see it has 1 and 4, 2 and 3, 1 and 2.
Okay, so I see.
Oh, those are, okay.
Yeah.
That's C.
Oh. Yeah. Yeah.
Okay.
See. Okay. So, always want to prepare your line list and make sure you notify individuals of what's going on. Number 3, scabies. Contact precautions for a patient with scabies can be discontinued when the patient has received effective treatment for.
It's D.
Yeah. 24 hours.
No, only.
What was that?
That crested, is it Norwegian scabies?
Norwegian
Yeah, it can be
scabies is
longer.
much
Yeah.
longer.
Yeah.
Crested or Norwegian
Yeah.
scabies, they suggest an alternative isolation approach.
You know, when I was watching that Jeopardy game at National APIC, that was one of their questions. They didn't know the name of crested scabies, there's Norwegian scabies, and so they were making all these jokes about scabies, but nobody ever came up with the right answer.
Oh, really?
Really?
I was like, where's Jessie? I know she knows all these answers.
Okay. Relevant employee exposure. A patient was admitted to the ED with severe headache, fever, and photophobia. A staff member who cared for the patient is requesting antibiotics because the patient may have meningitis. If meningococcal meningitis is confirmed, chemoprophylaxis would be indicated for all the following individuals except the LPN who did not have direct contact with the patient's oral secretions, the EMT who performed mouth-to-mouth, the resident who did not wear appropriate PPE during intubation, or DD/RN who suctioned the patient without wearing a mask.
Hey.
Guess they're all going to London anyway.
They're all good. Right. Yeah, they'll go behind. Somebody helps.
Individuals without direct contact with oral secretions do not meet exposure criteria. There you go, low risk. And the last question, the need for education. The need to include employee education for infection prevention is included in all of the following program components, except the facility infection prevention risk assessment, the facility's infection prevention program plan, the annual facility budget and allocation of resources, or the facility's 5-year strategic plan.
Yeah. Okay.
The risk assessment, right? Okay, strategic plan. Very rational. Strategic plans determine the direction organizations should go in the future and what the organization must do to reach that goal. So essentially, they don't include department-specific goals. So there you go.
Thank you for doing that.
We
Kathy.
stumped you.
Yeah, that was
Yeah.
a good one. Management one.
Yeah, I agree.
All right, well, we have time for roundtable if anyone has any burning questions or anything they want to mention. I will say that Kathy did just have a successful state CMS survey. She closed earlier today, and there's very limited findings. I don't know if you want to maybe share anything that they were asking about or what the focus was.
Well, with infection prevention related, they looked at our pneumococcal vaccines, how are we tracking them to make sure that they're happening, and then they specifically looked at whether or not the patient was given the VAS on those that declined the vaccine. Because, we had it all documented for those that received the vaccine, because it's all under the things, but our APIC program doesn't have a good process that says that they were given the VAS when they declined it. But all of our patients are given to it, we just didn't have it documented, so that's something we're just going to have to clean up. So they really focused on that, and then whether or not there were policies for the kitchen, infection prevention policies for the kitchen, we said no, because we hire Sodexo, and Sodexo, we use their policies and procedures, so there were some issues in the kitchen, but I felt like I was thrown under the bus on that one, and I said no. Since our surveyor was not the nurse surveyor, he didn't ask about any questions on our risk assessment or plan or any of that kind of stuff. Like the nurse usually does that every year, but this year he did not ask anything about that, which I thought was interesting.
Did they ask about your water management plan?
They did not. That's, we got that hit hard when the life safety people came back in June. So
Yeah.
they didn't ask any, these surveys didn't ask anything. And then we were able to clean up some of the stuff with the fully charting and that kind of stuff, so they didn't go into any of that stuff.
Kathy called out the surveyor for not washing their hands.
I did. Oh, Texas, she didn't know how to don and doff, so I showed her on the very first day. And so I had to make sure she took her stuff off right. And then the second day when she was doffing, she got part of the gown caught underneath her foot, and she walked all the way down the hall with it. And then later the third day, she came out of her room with that thing in her hand. And so I sick the director of nursing. I said, "Go tell her. I told her last time. You have to tell her she didn't wash her hands this time." So I was like, "Wow, man, she's just really not cognizant of the infection prevention stuff." I didn't think so. Yeah, it was kind of
She's
like,
probably not writing that part of this. 20 by 67.
And then they wanted to go watch a glucometer, a glucose check, and when she realized it was in the isolation room, she didn't want to go in anymore. She's like, "Really? That's the room we're going to?" The room it's in. So,
roundtable items or anything? Yeah. So.
I was just curious if anybody else has seen diarrheal illness. And I don't know if it's just randomly going through, but we heard stuff, and it seems like it's, fever, not, it doesn't sound like
Not
viral.
patients, this is in employees.
In employees, because it's more fever chills related with nausea, vomiting, diarrhea, and more prolonged, but I haven't necessarily seen on our foodborne a spike in anything per se. Last week, Campy was a little bit higher, but I was just curious if anybody else has seen that, or if we're just randomly, it's not all been related though, of the exposures and not necessarily people that we know, but I don't know where the exposure is happening exactly.
That's what your reason monkey is.
So, I don't know, if you guys have anything?
I would say in the summertime, yeah, we see an uptick in general, so we're definitely seeing it.
Kim, I have a question. Have we been seeing more pertussis lately?
We have been seeing a little bit more. We're kind of at the point of starting to think about putting something out within the community, but we're not quite at the level where we would typically do that. But yeah, we're seeing a little bit more.
Yeah, we've had quite a few pertussis exposures recently, so I was just curious. Any other roundtable items?
Anybody on the phone have a question?
This is Liesel. I was just going to say, it might make our exposure workups less frequent if there's some communication that it's actually going around.
People know to look for it?
Yep.
That helps with for patients this week.
For
Oh, I have an actual exposure, and we're in the few. It's questionable, but.
All right, Walter.
Just you need to have a question.
I have a question. If anybody here has used the duck method of doffing gloves and what you think of it?
Using the beak method?
Beak, yeah.
I call the duck thing too. I call it the duck, I don't know why. Because it's a
Yeah.
So,
Megan's on the phone. She's a huge proponent of that.
Really?
Oh, yeah.
Okay.
sorry, what method is
The
that?
beak method is, I think we all kind of naturally do it
You
anyway.
put it over, and then you have a little thing, and then you
Oh,
grab the other glove, and then,
Oh, yeah, I don't know what's called that.
yeah.
Yeah,
Yeah.
just so you're not contaminating.
Yeah.
Right.
It's glove to glove, skin to skin. That's the first one. And the second one is doffing, if you have a gown on.
Yeah.
The CDC allows a second way to roll everything
Right.
out.
But there's an article in the APIC journal about it, and their study was done strictly on just glove use, not on the whole PPE.
The whole PPE.
Because a lot of what is done, you're not using the total
PPE, yeah.
PPE, you're using gloves. And so I kind of researched that at my facility, and some people who were familiar with it really felt like it was so complicated to try to get it right, to get the that they felt it was more of a chance of contamination. So I wondered what other people, if they've really tried it and really believe in it, don't know how far to push something like that.
Megan, are you on the call? Can you hear us?
I am. Can you hear me?
Can you speak to that, the beak method, and your feelings about it?
I really like it. I think it is the best method to take gloves off. But it does require a little bit of knowledge and training, although technically every type of glove training does. So once people get the hang of it, I think they find that it's easier. I can show everybody next time maybe, if I'm still around. If I'm not in a hospital trying to push baby out. But yeah, I'm happy to do that. So I personally just think it's better, and even if it does require a little more education, it's the right way to do it in my mind. But that's just my opinion.
Yeah, and I found, I think it was the University of Nebraska, they have a really nice, like, step-by-step how-to with pictures.
The blue gloves?
I think they're,
Yeah, I have that one.
that one's helpful, but I know Megan, when she was getting her PhD, she has a PhD in virology, and so she was working with some, like, highly pathogenic viruses, and that's the preferred method in those settings, in those types of laboratories, because it is the most effective. But it does require, some...
Can you share that, please, with us?
Yeah. I can send that out to you guys.
I would have to say after I read about that, anecdotally, I went around and I think most people contaminate their hands when they're taking off their gloves.
Yeah,
Totally.
we're terrible
So-
thoughts, yeah.
Yeah, well, not, and that's without the gown, because we promote, you know, taking off of the gown when they're just using gloves. I think they contaminate their hands all the time.
And in that article,
In their hands.
there was also just a sentence that mentioned that with C. diff, it might be a good idea to contaminate with the gloves on, decontaminate. And so it didn't go into any detail, but I'm thinking, what, with 1 to 10 Clorox? I just.
So that can be like the Ebola thing where they clean their hands with a hand sanitizer? Clean the gloves with the hand sanitizer?
Yeah, well,
Is that what they're talking about?
Yeah, but with C. diff, it is
Yeah.
Does Ebola really get killed with hand sanitizer? I
Yes.
don't know. Does it? Okay, because it's not Ebola. Okay.
C. diff doesn't, but Ebola does.
Although Shay says you can use hand sanitizer with C. diff.
Well,
And
I think
Non-outbreak situations. Is that because they think it's colonized, you think?
well, no, I think because it has a bigger impact on your other drug-resistant organisms, such as MRSA and whatnot, to use hand sanitizer instead of looking at the, benefits there.
Right. So that, I did read something a long time ago that sometimes they would recommend soap and water and then the antibacterial hand sanitizer. So that's where what you're saying would come in.
Mhm.
How about CAUTI rate, decreasing the CAUTI rate with getting specimens taken from colonized catheters? So for instance, the nurses are taking specimens from catheters that have been in place for like greater than a month, and so when we get the results back, they're of course positive or whatever.
What we have here at our policy is to approve the CASPA fully and Thursday morning get a specimen in.
Right. Is there like a certain amount of days? Is it less than?
Well, we
typically
kind of
less
made
than
it
3 days?
7.
Yeah, ours
It's kind of,
arbitrarily 7,
it's
too.
not real data, it's more like biofilm data than, studies on that, but yeah.
You do 7.
If there's not a risk to taking the catheter out,
You have to make that assessment as well.
But are they doing them on patients who are having symptoms?
Yeah, that's
So
right.
it's not colonization?
It was, well, one was with symptoms, and then the other ones were just, the physicians have gotten where they just kind of randomly ordering the.
Yeah.
See, that's what I think, that's where I think we need to stop that part,
Yeah.
right there. The
That's
random thing with no
barrier.
symptoms, why are they testing them?
And then we have one physician that we do we were doing ours if it's greater than 3 days removed and get a fresh specimen, put a new one in, but, the physician says, no, don't do that. It's been like 2 weeks old, and they're like, so we have the barrier between what the physicians are ordering and then what we tell staff one thing, and the physician says, no, don't do that, leave it in and take the specimen anyway, so.
The other thing too, if you look at the IDSA guidelines, the compendiums, they do recommend replacing indwelling urinary catheters if you suspect an infection. So if they're really truly suspecting an infection, they should replace it anyway. So take it out, get a clean catch if you can, or a fresh specimen. You should replace it regardless.
Good, thank you.
Good question.
Yeah. Any other questions or?
I got one more.
Yeah, sure, yeah. Bring it over here.
Isolation in the hallway, PP in the hallway. So say, for instance, we're doing therapy, rehab, they're going downstairs and moving toward a patient, but they're in isolation. So I'm seeing where the isolation is done like in group therapy, they take them all down, but then I've had, read things where it says, do the patients in isolation last. And then PP in the hallway. So I've read some things that say, use a gown in the front, and then use a gown in the back, but don't actually have them wear gloves and then the yellow gown in the hallway. And then I've read some things that say the opposite. So
Are we talking about the patient or the staff?
both.
Yeah, so we have the patient put on a clean hospital gown, and then our staff will remove their PPE, their hand hygiene, and then help the patient in the hallway. So we don't want them wearing this.
That's what I read.
We do the same thing with the clean gown with the patient, but then we do have staff wear the PPE in the hallway.
And I think it
And then we go
depends,
work with them at the table.
and I think it depends on, for our policy, if there's going to be any risk to the staff. Like, if they're going to be interacting with the patient,
Yeah,
then
they
they
might
need to be able
wear
to
gloves
protect
for that.
themselves.
Right.
So they.
Most times so we don't recommend they go to group therapy with groups, we do individual, and then they're usually, bending their knees and all that other stuff, so we recommend that they do.
And if they're not contained or whatever, they probably should have therapy in their room. Because that's where the risk
If
is.
they're incontinent,
That
don't let
you're,
them come out.
Very good.
The wound or, condoms. Yeah. Very good.
All right, well, with that, we will conclude our, Martha has something.
Just a quick reminder, anybody on the phone before you hang up, go to that link and give us some feedback on the education and anybody in the room. We'd love to hear what, your feedback, so, thank you.
Yeah, thanks everybody for coming. If you want to stay for the board meeting, we're going to be having that. If not, you're free to go.
Thank you.